electrocardiogram is from a 70-year-old man which has a coronary artery bypass grafting in 2003, which is 10 years ago. He has chest pain since yesterday. The pain is aggravating after he had been working with a shovel in the snow. If you can interpret it, pause the video now and then continue and see if we have the same diagnostic. First, we are going to see the frequency. If this beat would be here is 300, then if it is here is 150, 100, 75, 60, so it is between 60 and 50, is like 58. The read is sinus because all the P's has like the same shape, and the P is positive in D1, D2, D3, ABF, and is negative in ABR. The axis of the QRS is in D1 because D1 is the derivation which has the largest R, or another way of doing it is that ABF is the derivation which is more isoelectric. The hypertrophy of the right ventricle is that the R be greater than the S, which is not, or the R be greater than 0.7 millivolts, which is 7 small squares, which is not, is like 4 small squares. The hypertrophy of the left ventricle is the sum of the S of V1 plus the R of V5 or V6, the one who is greater, and here is the one of V5 that is like 4, and 2 is like 6 small squares, and like 4 and 5 like 9 small squares, and 6 small squares are 13 small squares, and we have a lot of range. The hypertrophy of the atriums, of the right atrium first, is that the height of the P in D2, D3, and ABF, it has to be less than 0.25 millivolts, which is 0.5 small squares. So in D2 is like 0.2 millivolts, D3 maybe like 0.1 or 0.2, ABF 0.2, so there is no right atrium hypertrophy. The hypertrophy of the left atrium is that the P in D2 be greater than 3 small squares, which is 0.12 seconds, and here is, yes, almost like 3 small squares. Yes, here is like 2 and a little more. Yes, and in V1, the if the P is biphasic, the part of in which the P is negative has to be greater in amplitude than 0.1 millivolts, and has to be greater in the wideness than the positive part, which is. So probably this patient has a hypertrophy of the left atrium. The curvature of the T, it has to be concave upward. So here in V4 it is, in V2 it is, in ABF the T is negative, but it is, and in D2 it is, FCD1. And we are going to see the concordance of the T wave with the QRS. Here the QRS is positive and the T wave too, so this is concordant. Here the QRS is isoelectric or maybe a little more positive, but the T wave is inverted. Here the QRS is a little more negative and the T wave is inverted, so it is concordance. Here the QRS is negative and the T wave is negative, so here we have concordance. Here both are positive. Here maybe the QRS is isoelectric, so we can't know. Here the T wave is positive and the QRS is negative, and in this also, but in these limbs is permitted. And here the T wave is positive and the QRS is positive, and here the T wave is positive and the QRS is positive. The T wave is negative and the QRS is positive, so here is discordance. Now we're going to see the height of the T. It has to be less than half of millivolt in the lead, in the limb lead. So this is like 0.2 of millivolts. This is like where it's inverted, what is like 0.2, 0.3. This is like 0.3 of millivolt. In ABL it's like 0.3, ABF 0.3. Now in the precordial lead it has to be greater than 1 millivolt in order to be hyperacute T. So this is here would be 0.05 of millivolts, and we have a lot of range, so there is no hyperacute T. Here is also like 0.5, like 0.5 of millivolt. Here is like 0.3 millivolts, 0.2 millivolts, 0.1 millivolt. Now we are going to see the ST segment elevation at the J point. Here, this is the J point, and this is the basal line, and the J point is isoelectric. Here, the J point is elevated like 0.1 of millivolts. Here, the J point is also elevated 0.1 millivolt. In AVR, the J point is like isoelectric, maybe a little depressed. In AVL, the J point is maybe a little depressed. In AVF, the J point is isoelectric. In B1, the J point is isoelectric. In B2, the J point is like isoelectric. In B3, the J point is isoelectric or maybe a little depressed. In B4, the J point is like isoelectric. In B5, the J point is isoelectric or a little elevated. In B6, the J point is isoelectric. So we have ST elevation in D2, D3, maybe a little in ABF. So this is a STEMI of the left ventricle in the inferior wall. So it's the posterior descending artery, and we also have Q waves in D2, D3, and ABF. And we have sinus bradycardia. See you in the next ECG